So, it's been a long day. You've had a lot of thinking, I think. So it's a little bit of change of pace is what we thought we'd do. A little bit of a teaser, I guess, for tomorrow. So for those people who are coming tomorrow, this will help give some context. For those who aren't, now you'll know what you're missing. So I'm going to spend just a few minutes going through some preliminary slides, but we're actually going to get you guys involved in doing things very shortly. Minimum PowerPointing from this point in. So we are going to think about how we go about designing an archetype, okay? So getting practical. What do we want? A minimum data set or a maximum data set? I think we've made the point a few times. We're looking for the maximal data set, so that's the principle. It's an ideal maximum data set. We may not always get it in the first go, but that's the kind of thing that we're looking at. The notion of being inclusive rather than the old ways of doing things as a minimum data set. So each archetype's inclusive of all of the attributes that the clinicians might want to have about that one single concept. That's again what we're aiming for. So think as broadly as you can. It's a collaborative process. We talk about this a lot, but it is. Oops, we've gone too far. We want to brainstorm all of those things. We want to then organise it, and then we need to do something fairly significant. We need to identify existing archetypes. Now, that used to be quite difficult. It's much easier now because we've got CKMs. Now we have multiple CKMs, so it is actually sometimes worth investigating what's happening in some of the others. But the openEHR one and the Norwegian one, and occasionally the NETA one in Australia are the ones that have probably got the most advanced archetypes. So they're the resources that I would be using most of the time. Sometimes we will enhance existing archetypes where we find new requirements. Sometimes we use a process called specialisation, or we may just be able to add additional data elements to it to actually make it backwardly compatible but still useful. And last is where we start to think about building a new one. We only build a new one where we cannot identify anything else. So it's not our first step, if you like. We always want to reuse existing archetypes in our templates wherever we can. So we want to think about that concept from every possible angle, the who, what, why, where, how, maximum, minimum, normal, abnormal. What are all of these components around this concept, whatever it might be? Simple things, complex things, because then we might think about how we arrange the data. Complications, think about everything inclusively, expansively, talk to your friends, whatever it is that you need to think about it very broadly. And we want to think again, a bit like that slide I showed this morning, is it narrative or is it structured? Silje said something just before that you always need a reason to record structured data, and I think that's a really good rule of thumb. If in doubt, just keep it simple and maybe just capture it as free text. But if you're going to force a clinician to capture structured data, there should be a good reason for it. And that might be around, it might impact on patient care through decision support. It might be for reasons of reporting. It might be for other reasons as well that you identify. But don't make people capture structured data for structured data's sake, all right? Or you're going to have a lot of very unhappy clinicians. The notion of the normal statements, the nil significance, the graphs, the diagrams, the photos, all of those things, don't underestimate the need for those as well. And we are developing patterns that help make that easier. Different clinicians prefer different ways of recording, keep that in mind. So we're thinking about specialists versus generalists, doctors versus nurses, other professions as well, all of that kind of thing. So I think you're getting the idea. Think about what we're using now. We've got paper forms, we've got electronic health records that are doing this kind of stuff already. Pull all of that information into our brainstorming process. Look at the national, state, local data sets. Look at all the specialisations. Look at all what the professional groups are doing. Internet, I mean, I must admit I do use Wikipedia quite often. I don't usually put it as a reference because I think it's not quite that accepted, but it's a great starting point for pointing to other references, papers, all sorts of things. So use whatever you've got. And I don't think I've ever looked up a textbook, to be honest, but I don't rule it out. It may be something that you have there that's useful. But talk to a range of clinicians too, all right? A broad range of clinicians. So this is where the blood pressure archetype started probably 10 or 12 years ago. It was something as simple as that, all right? We mind mapped basically, systolic, diastolic, the position, units that we're measuring it in, that's about it. Then we did a broader grouping, and we actually then started to look at what else might there be. And we included some other things like the 5 minutes, 10 minutes, paradox, which is when the blood pressure goes up and down when you're breathing in or breathing out, postural drop, when you stand up from sitting, sometimes your blood pressure drops into your boots and people faint, especially old people, all of those kinds of things. And you can see on the right-hand side over here, we started to look at some of the factors that are part of an observation archetype. So in fact, we've skipped a little bit at the moment to go straight into the design stuff, but that's the kind of thing, you're starting to think about what type of archetype. And for an observation archetype, which is about a measurement, which is clearly what the blood pressure is, we're thinking about the actual data, which was the systolic and diastolic. We're thinking about the state of the patient at the time when you measured the systolic and diastolic. So if they were running on a treadmill, you might think differently when the blood pressure's high than if they were sitting at rest, that kind of thing. The protocol of how it was done, so what size cuff and where it was, and in fact things like is it a point in time or is it something that you would be measuring multiple blood pressures over a 24-hour period using a Holter monitor, those kinds of things. So there's different ways of trying to think about how that blood pressure might be captured, recorded and used. So research the existing archetypes, use the CKMs. There's the message there. I'm not quite sure why I've shown you APGAR score as the archetype when we're looking at blood pressure, but still, that threw me for a second. So we're using the existing archetypes wherever possible. This is a slide that we'll make available to you, but it's a decision-making slide about what class of archetype that you might use. So you've got in yellow there, the bright yellow is all the different classes, and basically a decision tree that will help you decide which is the one for the clinical content that you're currently using. And this is another table that you'll get in some of the slide sets that will come out, again showing that across the top here, across here we've got the different classes of the entry archetypes which capture most of the clinical content. They all have a protocol, right? The how and the data was actually captured. The observation has this notion of allowing time series and aggregations of data over time, intervals and so on. So that's the only one that allows us to actually capture that kind of data, which is appropriate for the measurements and so on, the evidence, if you like, for all of our decision making. It's also the only one, the observation, that has the state, so that you interpret the patient data in that way. And the action is something called a pathway, which we haven't shown you yet, which is about recording all of the various steps along a pathway of an order being actually carried out from beginning and the first thoughts about planning to do it right through the various phases through to completion, whether that's a medication order or a procedure, which might be anything from putting in a needle through to catheters and full sort of open heart surgery, that kind of thing. So they can be complex, they can be simple, but they're the principles. So we start to organise our brainstorming and we do think about which entry class. Is it an observation, an evaluation, instruction and an action? And then we identify the data elements separate from the protocol, from the state, from these events or time series and aggregations, pathway steps if we're carrying out some kind of process, and the concepts that need terminology and how we might engage with that. So it's all part of our thinking and our design. So that blood pressure archetype, we started to do that, and we have the 4 areas here, and we started to organise that these are all the kinds of events that we might have. A baseline reading, one 5 minutes later, one 10 minutes later, the postural change, the paradox, the systolic and diastolic, the position, that was the only thing that we had for state, cuff size, location and so on. So that kind of makes sense. But what have we missed? They actually talked to some other clinicians and they started talking about some of these other data elements and what happens at exercise. So in fact we created this little tree here where we said, well, they're at rest or they're just after exercise or during exercise, and we had some general thing here about exertion level. But in fact that we found was probably not enough either. We found someone who wanted tilt, so we added tilt. In fact, if we go back to that, you'll notice in the archetype, Silje showed you that there was a slot for an exercise archetype. So what we found was that all of these data elements we often needed in other archetypes. We needed it when we were recording the pulse rate. If they were on a treadmill, we also wanted to know that information in exactly the same way. And if we were measuring respirations when they're on the treadmill, we also wanted that context so that we could actually reuse that. And so we created a separate archetype. And so that's been created there as a level of exertion archetype that we can slot into any of these kinds of archetypes, because we found a common pattern that was being used across all of these different concepts. So this is where the kind of nesting comes into it. You get a sense of that? It's where we get common patterns being reused. Instead of just explicitly archetyping them in each one and trying to make sure that they're lined up and the same, we actually break it out, create its own archetype, and then we can reuse that same one in multiple different contexts. So we are always modelling exertion in exactly the same way, no matter which kind of measurement we're taking. Does that make sense? So this is the kind of thinking that's happening. We're looking at that maximal data set, and it should be as complete as possible, multiple sectors, multiple purposes, multiple priorities, whatever you can think of, we're trying to be as inclusive as possible. We're trying to represent a single concept within a single archetype. We don't want to model too much at once. Small is good, because we can always put multiple archetypes together. So in fact, that's where that level of exertion thing made a lot of sense, but not until we'd actually looked at what are some of the patterns that sit alongside the blood pressure, the pulse and so on. It became obvious we needed similar patterns being used in different archetypes. And we want to try and minimise the opportunity for overlapping concepts. So we organise by simple, generic, reusable principles. We're looking at content models that reflect clinical practice. We're not wanting to reflect SNOMED, we're not wanting to reflect our textbooks, we're not wanting to reflect the evidence necessarily, we're wanting to reflect what clinicians are actually doing and allow clinicians to choose how to apply the evidence. They shouldn't be evidence-based archetypes, if you like. This is not an academic exercise. This is pragmatic, sensible, down-to-earth, what our clinicians are actually doing. So this is the kind of, I guess, the master idea, if you like, that we have good design. So all of these things interrelate, right? Examination of fetus, uterus and cervix, fetal heart rate and so on. They're related to antenatal care. They may have common patterns, but they're quite independent, and we're able to actually nest and use them in all sorts of different orders if we get them designed right and so on. So minimising the gap between them so they fit nicely together, but also minimising any overlaps wherever we can. That is the end of the PowerPointing side of things. Now we get you guys to do some work, because we've just taught you how to build an archetype. Now you're going to do it. Okay? So collectively, we as a group are going to do this. And Silje is going to lead us through this.
So, whenever you're ready. We use this tool called XMind to do the initial brainstorming and organization of the concept bit of archetype modeling. You could use any mind mapping tool, but we found that way of working is a very good pre-archetyping step before you start doing things in the archetype editor, because it's much easier to move things around and change things in a mind map than it is in the archetype editor.
I would say every time I've tried to build an archetype in the archetype editor without doing the mind map, it's probably taken me 10 times as long, because I've made so many mistakes and I have to start from scratch. The time spent brain dumping and then organising is absolutely well worth that extra step.
So what I think it at least is a good idea to start with is to define your concept. And we talked about an archetype being an information model for one single concept. And the concept that actually you are going to make an archetype for today is it's got to do with tobacco use and the tobacco use summary. And we're going to talk about tobacco as a summary and not as a sort of diary that you detail how much you've smoked or how much snus you've used in the last week. It's more like, what are you doing now? What have you been doing before? But one of the key issues that we've been struggling with is tobacco use, all tobacco use one concept? Or is the concept nicotine use? Or is it smoking? Those are probably questions the clinicians will have to answer. But if you include all nicotine use, do you also include vaping, the e-cigarettes? Do you include patches? do you include gum? And if you include the e-cigarettes, do you only include e-cigarettes that use nicotine oil, or do you also include e-cigarettes where you can use, the THC oil that comes from cannabis? So it's really hard to set the boundary for this concept. Do you have any input on that? Would you keep, for instance, snus and smoking cigarettes separately? And what about smoking pipes? Or roll your own cigarettes? Are those different things? Or filters? Do we keep these things apart, or do we keep them in the same thing? And it's a good one. What are we going to use it for? The thing about tobacco use, they often ask you when you're admitted to hospital, they often ask you, do you smoke? Do you use snus? Do you drink alcohol, and how much? And that's the kind of context that we're talking about here. Not if you're going to, if you're part of a study where they have to know how much you smoked in the last month in detail. Just, do you use this? Have you used it before? Those kinds of things.
So we're trying to create a summary picture, if you like, of somebody's smoking or tobacco use, or this is the kind of thing. And there are common patterns that occur for alcohol use and common patterns that happen across other drug use and so on as well. So this is where the thinking kind of has to look at general patterns, even around addiction, and how we might record those sorts of things. It's something I've spent more of my life on, trying to tease this out than I would care to admit to. It's been one of the hardest things, and it's a useful discussion to have, not because I think we can necessarily solve it today, but it gives a sense of what are the questions we need to ask, and how do we actually start to try and tease out the patterns in this that might help us solve this issue.
And I think also a useful question is, do the data that you get out from the system, do they need to be separate for snus and smoking tobacco? Yeah, are they different things in terms of health effects, for instance?
I think we should go for nicotine. And then there are different uses or different ways of administrate nicotine to the body.
I don't think it's an easy question to answer, and we haven't been able to do it yet. But for this exercise, we're going to overrule you a little bit, and we're going to make it tobacco smoking history. So we exclude snus, and we exclude e-cigarettes because they're not tobacco. So we're sort of skipping over the problem of the snus versus the smoking, and we're also...
It's in the too hard basket for today.
Yes,
okay.
And also what about the vaping of THC, and what about the patches and the nicotine gum? So we're going to make it easy for ourselves. So clinicians, what do you ask patients about when you ask them about tobacco smoking?
The first question must be, do you smoke or not?
Okay.
And then how many is the normal question.
So it's yes, no, sometimes, and before.
Yeah.
Or previously. So what's the difference between no and never smoked again? Are those the same thing? No, okay. So so perhaps we should remove the no, because we've got previously and never smoked.
It depends if we're asking the question, do you smoke today, or is it an overall status? I think that's what we need to differentiate.
So you've got a quit date. Should we have a start date?
What age did you start smoking?
Yeah.
That's got significant impact on your morbidity into the future.
Mm-hmm.
What else might we want to know about their smoking patterns and smoking history over time?
I just wonder what the smoke question is, because we lost the sometimes smokers now.
So what do you think that should be?
Well, when you say current smoker, what's a smoker? If you smoke once a month, would you consider yourself being a smoker? Or where would you fit in?
We could perhaps have a pattern of smoking.
how often you smoke.
Or it could be just every day or occasional. So in Norway, there's a thing that's called a party smoker. Do you have that in Sweden as well? Yes. Okay. So is that something you would like to record here?
I'd be thinking in terms of the context of where you smoke. That might be something that's useful.
So triggers?
Yeah.
Or context?
What would you like?
What would you like? Is it a trigger that you go to a party, or is it a context?
If you smoke when you are alone, and less possible addiction if you only smoke in social situations, in groups. So social, alone. Way to put it.
What about how soon it is after you get up in the morning that you have to have your first cigarette? Like, I've put something up there that we haven't had mentioned before.
Could it be interesting to know if the patient is a passive smoker?
For sure. But would it fit within the concept of smoking tobacco yourself?
This is where we need to be clear about the intent of the archetype. So that was the kind of discussion around scope, because I think before we start to brainstorm, we need to fully understand. And what you're saying is absolutely important. We need to know about the passive smoking exposure that children have especially, but certainly collectively through our lives. I think this one, we could include that in there, but I think it's a slightly different pattern in we're looking at people's habits, and I think the kind of way that a lot of clinicians are using this kind of questioning is usually about this patient here is doing this at the moment, and potentially thinking about they're at risk, how might we go about changing behaviour, how might we get them to quit, those kinds of things, where passive smoking is a slightly different bucket of information. So they sit together if you're looking at risk from smoking, but I think there's two slightly different intent, if you know what I mean. So I would actually use that in a different archetype. If that's all right. But I mean, this is a good point. This is where you're starting to look at what are we actually trying to capture here and making sure we're really focused on getting the data that we want for this purpose in this one archetype. And now we've identified we need a second archetype to cover some of these things that are similar but not quite the same. So it's good. The thinking is very correct, and this is the kind of process that we need to go through.
And as you said, we are running out of time, so I guess we should just stop doing this and get on to the modeling the archetype. So
this is our archetype editor, and this is one of there's an increasing number of tools. So Eric has been talking about some of the online tools that are coming online. This one's been around for quite a long period of time, probably the first ones. So it's a little bit of a vintage or antique version, I suspect, but it's what I'm familiar with and it's what we tend to use. We're going to create an evaluation archetype. So I'm going to just say that's what we're going to do. This is my choice. So it's the type of archetype, and I'm going to call it tobacco smoking, and I'm going to create it. So it's in fact inserted the concept as tobacco smoking, and if I'm a good archetyper, I would describe what I mean by tobacco smoking. So I would be trying to define it very clearly, making sure it's not including the passive smoking side of things and so on. I can go through and I can add the purpose and the use and the misuse and my keywords and so on. I would put my name in there as the responsible person, so I can just fill my name in there and I'm ready to go, and then there's other data and so on that goes in as metadata. But this is the bit that we're actually going to be looking at. So on our mind map, we had smoke with current smoker, previous smoker, never smoked. I'm actually going to call that status, if that's all right with you. What's their current smoking status? So let's pop that in there. So I can type here as we go, and this is a text data type, and that allows us to have a default of free text or coded, or we can set a little value set, or we can link to an external terminology. But we've identified some values, so I'm going to add these values in here. And so I'm going to add current smoker as we discussed.
At this moment, you would have a look at SNO and CT also to see, do they have something useful or not?
Yes, but usually you wouldn't use the terminology binding at this level.
So, there's a number of reasons why it's not good to lock in value sets at this level, especially where we want it to be internationally applicable. So this is our tension. If we're building one archetype that we want to be interoperable with the whole world, if we're aiming for that very high thing, then in fact we probably want to have minimum data sets, and the only times you would put a value set in here is where it is absolutely ubiquitous everywhere all the time. It's unambiguous. So things like sitting, standing, lying for blood pressure, that's the way clinicians do stuff. They don't have a variety of values, but we may find that across all the different countries there are varieties of this code set. So that's where we need to be careful about that. So that's a good discussion about why we might not put a value set into an archetype. Because in deepest, darkest Nigeria or somewhere else, they have a different value set that's totally different to this for a different type of thing. I don't know what that is, but unless I can anticipate that, I wouldn't lock that down. But we have for the moment, so that's okay. We're showing you how to use the tool as well. If we look at pack years as the next data element, what kind of data type would that be? Because we have to think about what the units might be and how we might represent that. No, but let's perhaps look at doing a count, and we actually call it pack years, I'd suggest. And I would always be putting in a description here. I'd be typing in very useful things to describe it, and I can always put a little comment like examples about how it might be calculated. Eric, all of that kind of stuff could go in there. We can set minimum values, maximum values for counts. So each of the different data types has different constraints on it. And we also had how much. Now we didn't quite work that out, but I think what we probably need to look at is the form of the tobacco. How is it actually consumed? Is it cigarettes? Is it pipe? Is it I mean, if you actually look in SNOMED, if you look on Wikipedia, you will find wildly diverging lists of how people consume the different types of cigarettes and so on and so on. So based on that mind mapping, I mean, this is a very rough representation of how we would then go about interpreting that and putting that into an archetype. I'm not sure that it's of international quality at the moment, but it's a starting point, and it's the sort of thing that you might put into an incubator in that sandpit idea of the CKM, and then start to invite others that you know who have expertise in this area around addiction and so on to start to come and collaborate and critique it, provide ideas, feedback, and then you would iterate it. So this may completely change as a draft archetype that goes through this review process, whether it's formal or informal. And what actually gets published could be quite different to that, but that's okay, right? This is the kind of iterative process that we need to do. And I just wanted to kind of, I guess, get you started thinking about how you start to brainstorm a particular concept. When you look at some of the archetypes that are about to go out for review at the moment, we've got a medication archetype that's long, right? It's got huge numbers of data elements because it's looking at all of the requirements that we've identified in Scandinavia so far, although I'm not sure that Sweden's been too actively involved in feeding into that, but certainly Norway, UK, Australia and some other countries. And in order to be able to prescribe, like I showed you this morning, just the notion of how complex it is about timing and so on, trying to capture all of that kind of thing into an information model that we can use in our systems. So we start like this. It's just like this, and we just pull the resources together from all over the place. We use the mind maps, we reorganise. How many times have we gone through the mind maps in recent weeks? And that was when we were getting really close. That's not the really raw starting point. So the mind mapping process is really good, and it's only in the last couple of weeks we've actually committed it into an archetype that we put into CKM to then start to send out for review. So this is the process that we're going through day by day. This is our world. Whether you might think we're absolutely crazy, or you might have enjoyed that, I don't know. I just hope it was some insight. And it will feed into some of the process that we do tomorrow. Is there anything else?
Not that I can think of, no.
Okay. Thank you.
Thank you very much.
Thanks for your help.